If you have any questions during the webinar, write us in the chat. We will send put our email addresses there as well, me and my colleague Darren, who is also on the call. And with that brief introduction, I want to give the word to Professor Patrice Jissendi. Patrice, the stage is yours.
Thank you, Frederick. I'm honored to welcome you to this session. All of you who have been able to join. I want to thank the board for allowing me to handle this webinar, which we mean to be the first of a long series. I will soon share my screen. I'm already sharing my screen and you can see the case, but before I go through the case, let me tell you how we're going to proceed. We will go through the case together using the Collective Minds Radiology platform. Some of you may have already subscribed to CMRAD and now have access to the case. If you are therefore able to access the case on your computer, may I kindly ask you to be synchronized with the other participants and to look at the same images as those displayed on the shared screen, and to move on step by step with everybody in the same order. You may review a series that has just been discussed on your own, but please do not move on to the next series before I get to the corresponding point. We want the session to be interactive in different ways. As Frederick said during the session, from time to time, you will be asked to give your opinion by choosing one option from a multiple choice question. You will have 20 seconds to vote for only one option. After all the series are discussed, I will move on to the teaching points using a shared PowerPoint presentation. Thereafter, you will be allowed to ask questions using the chat tool. Since this is our very first experience, we have restricted the use of microphones. Sorry for that, and thank you for your understanding. So, are you ready? Let's get started. We are now on the CMRAD platform, and this is the clinical information about the case we're going to be discussing tonight. Simply multi-lobar brain hemorrhage, it's a question, and the case is a 51-year-old male presenting with left upper limb weakness since 2 hours, currently under treatment for urinary infection, and the patient still has lower belly pain by the time he presents to the hospital. No history of trauma, no alcohol drinking, no smoking, and he exercises often. No COVID-19 history. The patient's father died at age 50 years from heart attack. At admission, the patient had normal temperature, normal blood pressure, normal cardiac pulse, and he was fully conscious. The neurological examination found a left hemiparesis involving mainly the upper limb and also a left facial paresis. The first thing we're going to do is to look at the non-enhanced CT images in the review mode. These are the non-contrast enhanced imaging displays on the 3 orthogonal planes. Then let's scroll the axial images from the bottom to the top. Let me put it like this in a single display layout. In the posterior fossa, we didn't find any abnormalities. But when we get to the supracentral level, you can see here at the frontal lobe base that there is some hyperdensities on both sides here. And higher up, you can see that a hypodense area is surrounding the hyperdensities on the right as on the left. And then higher up, we find a large hyperdense area with mixed densities. You have very high densities here, and if I take a region of interest, you can see that the mean is 73.61 Hounsfield units. It looks like some recent hemorrhage. I will come to that later. And if we look at the same lesions using the other planes, you see here the frontal base lesion on the left, and on the right, a little bit more anterior to the left one, you can see here the hyperdensity very close to the skull base. When you look at the larger lesion, which is frontal prerollandic, on the right, you can see that the densities are mixed, various, and even maybe there is a flute level here that you can see with a clear separation. And also on the coronal plane, if you look very closely to the lesion, you see that there is a tight connection with the leptomeninges. I won't show you the images in bone window. There was nothing remarkable in the inner bone table here adjacent to the lesion. So another thing that I can show you is here, very close to the bigger lesion, you have another small hyperdensity, which is cortical, subcortical located, but it looks similar to this one. So given these findings, do you agree with the diagnosis mentioned in the report talking about multi-lobar brain hemorrhage? So this is the first time you're gonna give your opinion by voting and choosing one option among the two that will be disclosed to you. Go on voting.
Okay, we'll give a few more seconds. Okay, let's end it there.
Okay, thank you, Ferry. Can we get the results? Okay, so 65% agree with the diagnosis of multi-lobar brain hemorrhage. Okay, let's see if we have some other arguments or other findings that we could pick up by reviewing again the non-enhanced brain CT. When you look at these hyperdensities, it doesn't look like a lobar hemorrhage, which is often roundly shaped, but it looks like something that follows the gyre and is very close to the brain skull. In the case of head trauma, we would have thought that maybe it's a traumatic lesion from contusion of the parenchyma that have hit the skull base during the trauma. But there is no story of trauma. But it's kind of bizarre if we talk about spontaneous brain hemorrhage with this shape of the lesion. So would you have injected the patient? I think so. Anyway, a CT angio was performed to look for vascular malformation, and subsequently a contrast-enhanced brain CT was done, which I disclose the images to you right now. The angio did not show anything, any vascular malformation. So let me put side by side the non-enhanced and the enhanced CT images. No enhancement was found in the posterior fossa, and when we reached the level of the frontal lobe-based lesions, we see that there is some enhancement here. And you see the lesions are better seen because of the enhancement, right? And surprisingly, you can see before we reach the bigger frontal lesion that there is some enhancement of the impandima in the anterior part of the frontal horns of the lateral ventricles. And even there is some enhancement here, partial enhancement of the cortex of the insula, the right insula. And when we move higher up, we see that there is also a kind of enhancement of this lesion, which is cortically located close to the hemorrhagic lesions here. Higher up, the densities are quite the same. I can just measure it once again. Okay, you can see that the mean was 73.0.2 and you go up to 75.36. So there might be some enhancement there, but because of hemorrhage, it's difficult to differentiate. Anyway, all the lesions that were seen on the non-enhanced CT are enhancing. And in addition, we get some other lesions that appear as bright and taking gadolinium, iodine contrast. Here, there might be some other lesions. And also here in the frontal areas, you see some hyperdense lesions enhancing there. So given the new findings, to sum up, we have multifocal hyperdense lesions, some of them being obviously hemorrhagic, and all of them enhancing. Given the clinical information and all the CT findings together, what is your diagnosis now? You have to choose among 4 options. The first one being multi-lobar brain hemorrhage, the second multiple cavernomas, the third hemorrhagic metastasis, the second hemorrhagic infectious disease.
Polling is in progress. We will wait 15 more seconds, I think. Okay.
Okay, so 46% have chosen hemorrhagic infectious disease, maybe referring to the urinary tract infection that was reported in the clinical information. And also I can see that most of those who have previously chosen multi-lobar brain hemorrhage have changed their mind. Okay, that's fine. Let us comment again, just for a second, something on the CT. Look at the ventricle walls of the frontal horns. Don't you think that there's something, this is an unusual appearance of the ependymma, like hyperdense, but not very hyperdense? You can just ignore it when scrolling the images and it doesn't drive any attention, but it's something really unusual. And we will see how it looks like on MRI. And I know you can't wait to discover the brain MRI findings. So let's go to the MRI and review step by step, sequence by sequence, all the findings. I will start with the diffusion weighted images. And let me put together just a scroll, go through the images, and just to show you that there is no obvious hyper intensity here, except that these lesions which displays hemorrhagic components is obvious on diffusion, and you have a bright rim around the hemorrhagic collection and some susceptibility artifacts, but except that lesion, nothing is found on the diffusion weighted images. But if we put together diffusion weighted images and the ADC maps, you can see that on the ADC maps, the lesions are more obvious. For example, the frontal lobe-based lesions, you can see the dark signals here corresponding to those lesions, and the hyper signal around the lesions that could correspond to some edema. And higher up here, you clearly see the diffusion restriction on the ependyma layer of the frontal horns of the ventricles. And higher up, you see these susceptibility artifacts showing that this is really a bleeding, a massive bleeding, and a collection of blood within the parenchyma. Okay, the next sequence would be therefore the T2 gradient echo sequence. Okay, we don't see any dark signal on the frontal lobe base, maybe because those signals are covered by the susceptibility artifacts, but obviously this was the big hemorrhage here in the frontal right frontal lobe. But interestingly, if you look at the lesion that was close to the big hemorrhagic lesion, you don't see any dark signal. And all over the brain, except at the skull base, you don't see any hemorrhagic component of the lesions on the T2 star. Then we can move on to the T2 turboscreen echo on the coronal plane. Here we go. So here you have the hypersignal T2 on the frontal base lesion, extending to the ventricle wall, there, on the left. And you also see the blood collection here. And you may see the connection to the leptomeninges as this small nodule, which appear partly dark and partly isosignal to the cortex. And you can see also the regularity of the inner bone, adjacent bone. So the bone was not involved. Then we can move on to the FLIR images. And basically, you will find the same lesions as on the T2 in the FLIR images. And one surprise is that if we move up to this big hemorrhagic lesion, we don't see any hypersignal corresponding to the cortical lesion, the small cortical lesion. You do remember it, that was seen on the CT images. Now, the best sequence, I think, would be the T1. And what I will do here, to make it clear, is to put the non-enhanced CT images side by side with the T1 images. And we will try to look at the same slices, starting with the frontal base lesions. Okay, you do see here the gyroform appearance of the lesions. I just changed the window to make it more prominent. And you can see the disposition, the gyriform disposition of these lesions that appear hyperdense on the CT. And when we move up, you don't see any hypersignal here on the ependymal surface of the frontal horns, but it was slightly hyperdense on the CT. You clearly see here some other lesions that we may have missed on the non-enhanced contrast CT, even on the enhanced contrast CT, at the level of the right insula. Is really hard to see, but we can pick up some lesions there. And this one, the frontal anterior, is barely not seen on the CT images. When we move higher up, we see also these other lesions there that were appearing hyperdense on the CT. And if I zoom in, you can see that the superficial layers of the cortex are involved bilaterally. And indeed, when we reach the biggest lesion, we can see some signs of hemorrhage, recent hemorrhage here. And what we find here is the lesion that appeared hyperdense, which is not seen on the T2 gradient echo, but very well seen on the T1 without contrast injection. And there is another one on the left side that you can see here. Even when we go higher up, we can see another one here, which look extraaxial. And then we're going to put together the actual T1 with gadolinium and the non-enhanced actual T1. And what you see is that all those lesions are enhancing, strongly enhancing. You can see the frontal lobe base lesions. You can see the ependymal walls of the frontal horns. You can see all those extraaxial lesions here, or cortical, subcortical lesions. Even this one. And here, connected to the hemorrhagic lesions, you can see a little enhancement and thickening of the leptomeninges. And to the vertex, there is another one here, higher. So after having all these MRI features, given those findings, we should agree on the final diagnosis of hemorrhagic metastasis and ventricular carcinomatosis. But some specific MR features may lead to the metastasis origin. That is the point, because what do you think is the primary tumor for this metastasis in the brain? Then it's still time to vote. You have the choice between 6 options. Frederick, can you display the vote, please?
The vote is up.
Yeah. So the first would be renal carcinoma, or thyroid carcinoma, or melanoma, or bronchogenic carcinoma, or breast carcinoma, or choriocarcinoma. Which one do you think have given such a spread within the brain?
We will wait 10 more seconds. Okay.
Good, good. Well done. Melanoma. Okay. I have changed the order of this differential diagnosis, and the right order would be MR, CT, BB. M for melanoma because it comes first. C for MR. R for renal carcinoma. C for choriocarcinoma. T for thyroid carcinoma. B for bronchogenic carcinoma, and D again for breast carcinoma. So this is the top 6 most hemorrhagic metastasis in the brain. Okay, but you know, let me tell you the end of the story, because the right answer is also there. After learning the brain MRI results, the physician went to the patient and told him that given the MRI results, complementary and extensive investigation would be done to search for the primary tumor site. Surprisingly, the patient replied, "I know where it comes from. I didn't tell anybody since admission because I was afraid. I got operated on a couple of years ago for skin melanoma, and I was suspecting that it has recurred and invaded my brain because I felt weakness on my left arm." And the hidden detail is in the patient medical history. So even without the patient confession, we could guess the final diagnosis from the non-enhanced T1 weighted MR images, because melanoma metastasis disclose a specific T1 features, and this is one of the teaching points I will go through now. Let me share the PowerPoint presentation. So the first question is, how a skin melanoma metastasis to the brain? From the primary site of tumor formation, melanoma cells get into the peripheral blood vessels with several adhesions molecule complicity. As you can see here, AKT is one of the most active in this transition from the tumor site to the vessel lumen. And then moving with blood through the vessels, it enters the brain vasculature. After getting inside the brain, the fourth step is an arrest at vascular branch points. From there, metastatic cells extravasate by crossing out the blood-brain barrier, as you can see here. And then they stay close to the vessels. These cells have strong adhesive properties to the brain endothelium and remain in tight contact with the perivascular spaces, microvessels, where they proliferate using a way called vessel coaptation. That means they feed themselves through the blood-brain barrier. Therefore, the metastatic melanoma cells interact with astrocytes to initiate angiogenesis and build up new vessels thanks to angiogenic factor like VEGF-A. And then these new vessels are prone to hemorrhage because the vessels walls are very fragile. And also the blood-brain barrier alteration will lead to extravasation of contrast media. That is why these lesions enhance strongly. You can see here that the agglomeration, the density of the metastatic cells are partly responsible for the increased density on CT images. And the way the ependyma looks here is attributed also to cell metastatic cells density, but also, as we will see on the next slide, to the metal content of the metastatic melanoma cells. Why is melanin bright on T1 weighted images and often dark on T2 weighted images? This is the second point, and you can see here on the top, on the right, the pigment, the melanin pigment within the melanocytes. And this is the structure of the melanin molecule. And you can see that the melanin has high affinity for paramagnetic ions like iron, copper, manganese, and zinc. Also, melanomas prone to hemorrhage because, as I told you previously, because of the presence of new vessels, abnormal new vessels, but also the blood-brain barrier rupture. And in this figure, you see how the signal intensity evolves on T1 with the melanin concentration. And you can see that the T1 signal goes up at very low concentration of melanin. But on T2, you can see that the signal will drop at a higher concentration of melanin. Thus, we have a range of melanin concentration within which only T1 can show a hyper signal. That means something abnormal. And this is the case here, for example. If you look at the cortical lesion, it appears hyperintense on T1. It takes contrast, but is unremarkable on T2 and T2 gradient echo. And all that I have said is related to melanotic melanomas, because a few proportion of melanomas are amelanotic. That means the melanocytes do not have any pigment. A good way to remember about the etiologies of T1 hyperintensities, you can find that in radiopedia.org, is my best friend is pretty cool. But in this case, in the case of our patient, his best friend was not melanin. But it's a good way to remember about everything that is abnormally hyperintense on T1 images. M stands for melanin, B for blood, especially methemoglobin, F for fat and slow flow, P for protein content and paramagnetic agents, and C for contrast media and cholesterol. The high metallic content of melanocytes probably also accounts for the increased density on CT. Finally, okay, I said it, that you should be aware of the fact that these features are concerning melanotic melanomas and not amelanotic melanomas, which are pigmented. Thank you for your attention, and I will be glad to receive your questions.
Thank you very much, Patrice, and for a great lecture. For those of you who have questions, I'd like to begin with Romina Hassan, who had a question, who raised her hand his hand previously. Feel free to write your questions in the chat, and I will read it out loud. Okay, so we got a question here from Yasmina Abu Firas. I still don't understand why most tumors wouldn't be prone to hemorrhage in the brain, since the physiology of most tumors is an extension through vasculature, and they would all cause a fragilization of BBB.
Okay, thank you for the question. Yes, all the tumor metastasis to the brain using the vessel roots That's true. But as you can see here, there is a neovascularization of the metastasis itself. And that is the cause for a hemorrhage. It's not only the rupture of the blood-brain barrier, but it's because there are new vessels within the lesions that are prone to hemorrhage because the vessel walls are abnormal.
Perfect. Any more questions? Okay, so no more questions. With that said, thank you so much to everyone who participated on this webinar. One question. There was one more question. Could PET imaging help?
Okay, maybe PET was used in this case to see if there was an extent out the central nervous system of the tumor, but it was negative. So I don't know if PET could distinguish metastasis from melanoma from other metastatic types of metastatic cancer types. I don't know. I have to check about that.
And we got okay, one last question here from Dora. Is there a difference in the enhancement pattern of melanoma metastasis from the other hemorrhagic metastasis?
I don't think the way it gives some hemorrhage is different. The typical feature of the metastatic melanomas, the metastasis from melanoma is laying on the superficial layers of the cortex, and it has at some areas of the brain a gyriform pattern. And I think this is the clue. And when you pick up this sign, you may really, given the history of the patient, hypothesize on the metastasis from a melanoma.
And we have one final question, so this will be for sure the final one. In a nutshell, what could orient us immediately to metastasis and not MLH?
In a nutshell, what could orient us immediately to metastasis and not MLH? You need MRI, and you need to see on the MRI that all the lesions are not hemorrhagic.
Excellent. So I think with that said, we took up more time than we promised initially, but I think we all enjoyed it very much. Thank you so much, Patrice, for an excellent lecture, and for everyone who joined us this evening. As we mentioned earlier, and to get access to the case, you can sign up at cmrad.com, which is free for all doctors. And you will all who have an account get access to the link and the video recording of this link. We will also keep you posted about the forthcoming webinars. There was a question about that as well. So stay tuned for more information about the coming sessions. And also you should all receive an email following this event with a possibility to give your reviews, how you think this panned out, and if you appreciated it, and maybe give us some advice for the next webinar. So we hope to see you next time, and thanks again for joining. Have a good evening, everyone.
Thank you. Bye-bye.